morning once and all. My topic of presentation is hepatic artery thrombosis post liver transplantation. The overview of my presentation is going to be history, background, incidents, the risk factors associated, how to go ahead with evaluation and diagnosis, what are the management protocols, and the last but not the least is IL-based data. Coming to the introduction, hepatic artery thrombosis is one of the most feared surgical complications following liver transplantation. It is one of the common cause of primary graft dysfunction and graft loss. Most commonly it occurs within 10 days of liver transplantation. It's very rare after 3 months. Regarding early and late head definition, the timeline is very arbitrary, but most of the articles, most of the centers, they have used less than 4 weeks and more than 4 weeks as a timeline differentiation between both the groups. However, there are also other centers who use less than 7 days and more than 7 days as early and late head, depending upon the technical factors which is associated with early head and late head which is not associated with technical factors. Coming to the incidence varies between 2.5 to 9% in across the studies. This is one of the review article which has included a huge number of patients, 21,000 patients with 843 had. The incidence of early had in that study was 3.9%, and the incidence among the adult and children vary. There is a difference between the pediatric and adult patients, 8.3 and 2.9%. There is a difference in era, and initially it was higher, 6.9%. Nowadays it has reduced to almost nearly 4%, 3 to 4%. In that review article, there was no geographical difference between the incidence of hepatic artery thrombosis. And regarding the volume of the transplant performed by the transplant center, if the volume is more than 30, then the incidence of head doesn't make a difference. However, less than 30 transplant per year has got a higher incidence of hepatic artery thrombosis. Regarding deceased donor and live donor liver transplantation, there was no difference in that review article, and we are going to further discuss the difference between two, and not much difference between live donor and deceased donor as per the literature. Regarding anastomosis, that is whether you use microscope which has got higher magnification and loop magnification which has got up to 10 times magnification, not much difference between those two groups also. This is another review article with an overview having almost similar kind of result with which has added that the incidence has decreased over the time period. Recently the incidence varies between 2 to 4%. Regarding definition of early versus late head, it has been arbitrary. Some of the centers they use less than 7 days and more than 7 days. Some use 4 weeks as a cutoff time, and some other centers have used 3 weeks also as a cutoff time. But most of the literature are using more than 1 month, the older literature. But nowadays I have found the recent articles they are using 7 days as the cutoff differentiation between early head and late head. Coming to the risk factors can be donor related, recipient related, perioperative risk factors, surgical, which is technical related, kinking, stenosis, and the condition of the artery, and there can be non-surgical causes also which we are going to discuss in detail. And rejection as a non-surgical cause can have increased resistance to arterial flow leading to hepatic artery thrombosis. These two studies, they have discussed the risk factors associated with head in detail. I am going to discuss these two. The first one, as I have discussed, it's a huge number of patients. Early heart rate is 4.4%. And the second one is 1487 patients. This is an original article in which heart incidence is 7%, and out of those 30% is early heart and 69% is late heart. They have taken the cutoff time of 3 weeks. Coming to the donor associated risk factors, various risk factors has been studied as per that review article. The donor age greater than 60 year, lack of abio incompatibility, that has been studied by a lot of researchers, and living related and deceased donor, though in this article they have found a difference, but other articles I am going to discuss. And reduced graft and whole liver graft in pediatric age group. There is a conflicting difference between two studies which has been published in 1996 and 2005. The recent one says reduced size liver graft is a risk factor for heart. And other factors, which is low donor age and recipient to donor age ratio, has been associated with heart. And coming to the recipient factor, which has been studied for heart, there the experience or the volume of transplant performed in center, and other risk factors which are retransplantation, biliary reconstruction versus duct-to-duct anastomosis, and the CMV status of the patient. Most of the articles they agree upon when the donor is CMV positive and the recipient is CMV negative, that's a risk factor for heart. Since the CMV CMV disease itself is a risk factor for heart. The other risk factors which has been associated with recipient are retransplantation, less than 15 kg, that is pediatric group of patients, and metabolic disease in particular is associated with high risk of liver transplantation. We are going to discuss the individual articles also. Coming to perioperative risk factors, these are warm ischemia time, the number of products transfused, and this shows the difficulty of operation and the prolonged duration of the surgery, and duration of operation and cold ischemia time. These are the factors which are perioperative factors. They have been significantly associated with heart. This is surgical factors. Most of them would say when aortic conduit and supraciliar conduit is used, and end-to-end anastomosis in place of branch patch has got a high risk of heart. Replaced artery or arterial variation or multiple artery reconstruction and bench side reconstruction of artery is also a risk factor for heart. This is the second original article which has on multivariate analysis has found for early heart, the previous heart and number of arterial anastomosis and donor weight, low donor weight, that means pediatric age group, has been risk factor. And the late heart, the recipient age and the previous heart and the previous upper abdominal surgery and low donor weight and transplant operation duration, these are the factors which has been associated with heart. To summarize, these are the factors which has been there has been conflicting results regarding the risk factor of the heart, that is use of conduit, donor cold ischemia time, anastomosis directly to the recipient aorta, and the type of graft, whether whole size or reduced size in pediatric group. But however, on these points, most of the studies they agree upon that these are known risk factors like CMV positive donor and negative recipient. Retransplantation is universally considered across the studies as a risk factor for for heart. The arterial variant anatomy, low recipient weight and prolonged operation time are the risk factors which has been agreed upon by most of the studies. These are the non-surgical causes which can still be associated with heart, and we need to take anticipatory measures in these patients, like familial amyloid polyneuropathy. One study published from Portugal, where this disease is so common, they have found that the incidence of heart is 11.6% in comparison to 1.5% those who are non-FAP patients. Budd-Chiari syndrome, as you know, this is associated with hypercoagulability and portal vein thrombosis too. So this is also a risk factor. In our center also, out of all the patients who have developed heart, 2 patients had Budd-Chiari syndrome as etiology. Primary sclerosing cholangitis and the primary biliary cirrhosis, the cholestatic disease, they are associated with high risk of heart because of hypercoagulability. recipient diagnosis of hepatocellular carcinoma, those patients usually have low MELD and the coagulation status is more on normal or hyper side. They are also associated with HAT. Metabolic liver disease along with FAB, tyrosinemia and other metabolic like citrullemia, those are also associated with hypercoagulability. So more or less in these patients, hypercoagulability is the cause of HAT as a high risk for the HAT. Coming to the live donor liver transplantation, I could found 2 or 3 articles which are specifically focusing on live donor liver transplantation and the risk factor for HAT. This one from Japan published in 2006. 213 patients, 5.4% incidence of HAT, and the survival they have seen is in patients with HAT there is a survival difference with low survival of 58% versus 84%. Regarding the risk factors, they have seen recipient sex, female population has got a higher risk of HAT, and metabolic disease, which includes FAB and other metabolic disease, they have got a higher risk factor. Coming to the same study, the odds ratio associated with recipient female population is 4 and the metabolic liver disease is 4. So they have proposed more intensive anticoagulation therapy in those populations. Regarding the studies comparing both LDLT and DDLT, they have not found much difference between incidence of HAT. This is one study published in 2019 in Annals of Surgery. They have shown that early HAT incidence is similar between both the groups. However, late symptomatic hepatic artery stenosis, they have found it is more common in DDLT in comparison. So they went ahead to propose that LDLT is associated with lesser vascular complications than DDLT, and they proposed that they should perform more LDLT. That was the whole idea of because this has been criticized. This paper has been criticized in editorial too. And another publication looking at the risk factors of vascular complication between LDLT and DDLT. This is from University of Toronto. 145 patients compared in both the groups as a matched cohort, and they have found that there is no significant difference between both the groups, though you can see there are 6 hepatic artery thrombosis in patients with LDLT group. Coming to the clinical presentation, most of the early HAT patients, they will be detected in recent times asymptomatically, but whenever they have got symptoms, it could be transaminitis leading to graft dysfunction and fulminant hepatic necrosis. These are the common presentation in early HAT group, whereas in late HAT group, the more common presentation are bile stasis and cholangitis, cholangeal abscess, liver abscess, and biliary complications are more common in late HAT. This is another study looking at the clinical presentation. The difference again almost same. Allograft dysfunction and non-function is more common in early HAT, whereas the liver abscess and biliary complications are more common in late HAT group. The clinical impact of HAT, how this affect the graft and patient survival. As you can see, most of the studies, they agree upon that it has got to do with significant graft loss and mortality, and hence indication of retransplantation. The overall mortality in patients with early HAT is 33%, and late HAT it's almost 32%. Almost 1/3 of patients will have mortality if they develop HAT. However, most of these reports are from DC donor centers where they have gone for retransplantation as a major modality of treatment in those patients. And mortality in adults is higher than pediatric patients in patients with HAT. Coming to evaluation and diagnosis, the primary modality for evaluation of HAT is detected on ultrasound as a routine screening method, and the sensitivity and specificity 60% and specificity almost 60 to 90%. Confirmation is obviously by CT angiography or MR angiography. Regarding ultrasound evaluation, the TARDIS powers waveform, as you can see, low peak systolic volume with a gradual slope towards the diastolic volume, RI less than 0.5, and systolic acceleration time less than 0.08 second is associated with high risk of heart, that is impeding heart. But however, it has got low positive predictive value and a high false positive rate. But when we combine the peak systolic volume of less than 48 centimeter second along with these parameters, the specificity and positive predictive value, the increases at the cost of sensitivity. So what about the frequency of Doppler ultrasound that should be performed in a post-liver transplant setting? The frequency, it has not been clearly defined. It varies between center and center. Most of the center would use once a daily Doppler ultrasound. However, less centers are there who use this Doppler as in a less frequent manner. In our center, we use almost twice Doppler for at least 5 days, initial 5 days, followed by once daily Doppler for another 5 days. Sorry. This is regarding the utility of Doppler. Though incidence doesn't decrease by doing Doppler frequently, however, it has been associated with success rate of revascularization following the early detection by increased frequency of Doppler ultrasound, because the revascularization and its success rate is defined by saving the graft and saving the patient. In that cases, when you detect the heart in an early period, it's better to manage those heart than detecting it late, which is associated with already graft dysfunction and ischemic reperfusion injury. Coming to prevention, because this is the area where we can alter the management of these patients with heart. All the patients we have discussed, that is hypercoagulable state, non-surgical patients like familial amyloid, polyneuropathy, BCS, and primary sclerosing cholangitis, and all other metabolic disease patients, they will have hypercoagulable state. And another contentious issue is anastomotic technique, whether this can actually improve. I am going to discuss it in detail. But among these patients who has got hypercoagulability, background hypercoagulability, in those patients, we should look at the we should have early that is increased frequency of ultrasound. Along with that, we should adopt the anticoagulation early in their postoperative course. Coming to the anastomotic technique, whether this can change the incidence of heart, most of the studies they have found that there is not much difference between a different anastomotic technique and the incidence of heart. The most common method used is back wall first technique, in which the suture is taken at 6 o'clock, 6 o'clock and 12 o'clock. Then we turn the artery and do the This is the conventional back wall first method, where we twist the artery, then do the back wall first, taking all the knots on the outside. Then the artery is again retwisted back to its normal position and anterior wall is turned. This is the normal. And this is modified back wall technique, in which instead of 12 o'clock and 6 o'clock, the sutures are taken at 3 o'clock and 9 o'clock position, so that the artery doesn't have to be twisted almost 180 degree. This can be performed with just 90 degree twist. The other is the technique wise, that is continuous and intermittent suturing. Not many people would do continuous suturing nowadays. Intermittent suturing is preferred method for atrial anastomosis. The other rarely described techniques are W technique, and one technique that we are using is clockwise technique nowadays. Previously we were adopting this back wall first technique. I am going to discuss this later on. Regarding microsurgical and loop magnification, though some of the Japanese and Eastern centers, they have shown that microsurgery surgical technique is better than loop, but most of the studies they have disagreed that it's a risk. The similar kind of incidents has been found between both the groups. This is the technique which we are using right now. We have used 244 initial transplantation with conventional method, and the recent method that we are adopting is clockwise technique in which we take the first suture is taken at 6 o'clock, then the posterior wall is completed, followed by anterior wall. In this case, we don't have to twist the artery, hence the risk factor, which is intimal stress, which happens when twisting the artery, is essentially avoided in this technique. Coming to the management options, the once HAT has developed, this will be decided regarding the timing of HAT, whether early HAT or late HAT is there. Three modalities of management. One is revascularization, either by operation or by radiological intervention, retransplantation, and conservative modality. The type of intervention is usually decided by the timing of the development of HAT. Coming to intervention radiology, it has to be individualized. It decreases the need of transplantation. Should be preferred in patients who are asymptomatic, who doesn't have graft dysfunction. This is the largest series which has been published in 2012 regarding endovascular management. 360 patients they have included. 13 patients had HAT. The initial success rate was 81%. However, this is associated with risk of rethrombosis, that is almost 33%, and the risk of hemorrhage too. So overall success rate is 54%. If we combine that with surgical treatment, the overall success rate is 69%. Hence, the endovascular treatment plays a very definitive role as a less invasive approach. This is the review literature regarding endovascular treatment. The success rate can vary from 17% till 100%. On most of the centers with catheter-associated thrombolysis, they almost have a 50% of success rate. Regarding the HAT and its management in live donor liver transplantation, in particular, one study published from Korea in year 2018, they included 827 patients. They have got a very low HAT rate, that is 1.9%. The patients who underwent surgery, they have got 100% success rate in terms of recanalization and revascularization. And those who underwent endovascular procedures, they have got 45% success rate. The overall success rate in this group was 62%. Of the patients, there were failed recanalization in the late HAT group. They found that on imaging there is neovascularization with intrahepatic artery being present on subsequent imaging. This is the overview of their management protocol. As you can see, 7 patients, that is 43.8% patient had early HAT. You can see there is a difference in approach in early HAT and late HAT. In early HAT, 4 out of 7 patients underwent surgery. All patients could achieve revascularization. One patient had biliary complication and one patient had graft failure, and this patient has got mortality. Whereas endovascular treatment, they adopted 3 out of those 7 patients. They were successful in 2 cases and 1 was failure. And liver transplantation and overall mortality was higher in early HAT group in comparison to late HAT group. Yes, sir. Very few slides are there. When we look at the late HAT, the common technique that is used is endovascular procedures. So they have adopted that in 8 patients in comparison to 1 patient who underwent surgery. And the mortality in those group, in late HAT group, is lesser in comparison to early HAT. However, the biliary complication is more in case of late HAT. Coming to the ILVS data, we have got 879 liver transplantations, majority of them live donor. The hepatic artery related complication is 27, which is close to 3%. However, the hepatic artery thrombosis in particular, we had 27 patients, which is 2.38, 21 patients, which is 2.38%. Among them, the early HAT, as defined in our submitted manuscript, is less than one week, and late HAT is more than 1 week. That is 17 patients had, most of them had early HAT. This is a demography of the patients. Most of the patients who had almost all patients are adult patients. Only one patient out of all the pediatric patients had, and as you can see, there was no HAT in DDLT, though number of DDLT is still 65. This is the other parameters. This is the etiology. Regarding etiology of patients with CLD, ethanol and cryptogenic were common etiology that we transplanted upon, and the donor relationship, most of them are son and wife was common donors. This is the regarding duration of surgery and intraoperative parameters. Coming to post-operative measures, the day of detection of HAT is 4 days, that is in early HAT group, that is 1 to 5, and 17 were had early HAT. The graft dysfunction was associated with 39% of the patients. Biliary complication was seen in 22% of the patients, with 30-day mortality of 90-day mortality of 22%. 4 were out of those 6 were HAT related. Presentation in our cohort, most of the patients were asymptomatic in view of frequent use of Doppler ultrasound, that is twice daily in initial period. Almost 23%, 85% of the patients were asymptomatic, and rest had graft dysfunction and biliary complications as their presentation. 4 patients had attenuated flow out of those 27 patients. And this is the enzymatic evaluation of among the HAT group and control group. As you can see, there is not much difference between, because most of the patients were detected in initial asymptomatic period. Coming to the flowchart of management that we have adopted, total 27 number of patients, HAT 29, other complications, hepatic artery related 6 patients. Surgical revascularization was adopted in 7 patients, out of which the recanalization revascularization was successfully achieved in 4 patients. Unsuccessful patients were 3. Those patients again underwent endovascular intervention and thrombolysis. Coming to the 13 patients who underwent straight ahead for intervention radiology, particularly those patients who are more than 5 days into post-liver transplantation, successful recanalization was achieved in 7 patients. In 3 patients, in unsuccessful patients, they underwent surgery, and rest of the patient re-thrombolysis was attempted. So, success rate of the primary intervention by either surgery or intervention radiology was 57% and 53%. This is one patient who has got hepatic artery in thrombosis. This is a left lobe graft who underwent splenic artery embolization for better flow, followed by thrombolysis, and you can see the left lobe intrahepatic flow has been achieved after revascularization by intervention radiology. This is hepatic artery low flow because of steal by splenic artery and GDA. Both the GDA and splenic artery has been embolized. Now, because of low flow, there was no thrombosis in this patient. The patient with right lobe graft, the intrahepatic hepatic flow has been achieved. This is the biliary complications which has been found in our cohort. 22% of the patients has got biliary complication, 3 equally distributed between leak and anastomotic stricture. Most of them were successfully managed by either endoscopic or percutaneous method. Regarding the manuscript which has analyzed almost 650 patients with a HAT rate of 2.4%. Yes, sir. I'm done with regarding what we have found is change in technique has been associated with low risk of HAT, with the recent technique has been associated with quite low risk of HAT, which is close to 1.5%. This is the survival among the HAT group. The survival is decreasing in comparison to CLD group. However, on statistical analysis, there was not much difference. However, the number is too low to have a prediction regarding the mortality. This is the IL-based protocol that we are following right now. This is the frequency of Doppler in our post-liver transplantation patient. Once heart is suspected or detected on Doppler, we confirm it with CT angiography. And if it's less than 5 days, that means initial post-transplantation period, we usually go for surgery or revascularization method. Thank you.